All right, we are live.
Good morning, everyone, and welcome to our first GIC meeting of 2021. It is so nice to see so many of you, and I am excited for a packed agenda. It will go until 11 a.m. as per the notice we received, so I hope everybody's year is off to a good start. In order to get started, I wanted to make sure that you had a chance to review the minutes, and if there is a motion to approve, I will take it. However, while I pause there, I want Andrew to just make a comment on the minutes for those of you who are ready to approve them. Go ahead, Andrew.
Okay, there was an edit to the minutes after they were sent. I just wanted you to be aware. It's on page 6, section 4, and benefit procurement was the heading. And it we had garbled Mr. Kane's comment slightly. What it does is, what he said was that the overall preliminary average increase was 5.8%. The minutes said that was only for the non-Medicare plans, but it was inclusive of the Medicare plans, so we corrected that. And the other correction in that same paragraph was that he explained that there was a possible range of 4 to 7% for individual plans once finalized, but what he had actually said was it could be lower than 4 or higher than 7 for some plans. So with those corrections, that will be in the final minutes.
So thank you, Andrew. Do we have any discussion on that, or is there a motion to approve the minutes?
So moved.
Second.
Second? Okay, great. So all in favor, I'll pass it over to Andrew for roll call. I approve. Andrew?
Co-chair Kaplan,
Yay.
designee Roeder,
Aye.
designee Butler,
Aye.
Commissioner Shabbat,
Aye.
Commissioner Chapdelaine,
Aye.
Commissioner Choate,
Approved.
Commissioner Clenard.
Aye.
Has Tamara joined us?
Yes, I have.
Commissioner
Aye.
Davis,
Yes, aye.
Commissioner Drake,
Aye.
Commissioner Edmonds,
Aye.
Commissioner Gentile. I'll skip over, he may still be having issues. Commissioner McEnany,
Aye.
Commissioner Murphy Rodriguez,
Yes.
Commissioner Seneko,
Aye.
and Commissioner Tim Sullivan.
Yes.
The motion passes unanimously, but let's see if Commissioner Gentile has joined. He has. Commissioner Gentile,
Is Andrew there?
I'm here.
Oh.
Commissioner Gentile, we are taking a vote on the minutes.
We can circle back with him.
Okay.
All right, well, thank you, Andrew. It does seem like the minutes were approved. I want to thank all of you for that, and I'll pass it over to Matt. But before I do that, I did want to welcome Emily to the GIC. So for those of you who have worked with Emily at A&F, she has joined Matt's staff, and I'm thrilled to welcome her. So looking forward to working with her and others that make up the hardworking team at the GIC. So welcome, Emily. It's your meeting.
Thanks.
Go ahead.
Thanks, Madam Chair. Janine, if you go to slide 4, for the Executive Director's Report. First of all, good morning and welcome everybody, commissioners, welcome to my staff and to those who are following along the meeting on YouTube. Just excited to start a new year with you all, so thank you for making the time. We have a busy agenda today, as my chair noted. Under the Director's Report, we've got a number of things that we want to cover briefly. Janine, if you can go to slide 5 for the calendar. So here you'll see kind of where we've been on a number of key priorities for the agency over the last several months, actually going back to the beginning of the fiscal year and looking ahead for the next few months anyway through the end of our first quarter. So you'll note in the purple here, we are in step 2 of our rate and plan design development for our FY22 offerings. So today we'll be going through some modeling that we've done of potential plan design changes. We will be discussing those today and taking feedback from the Commission. And then we'll come back to you at our February meeting for a vote on any potential plan design changes. And then we'll wrap in March with the vote on final rates. We are here today again for our annual out-of-pocket report, which Margaret Anschutz, our data analytics manager, will provide some really interesting data, particularly about out-of-pocket in the era of COVID. Our one vote for today will be the life and long-term disability procurement, the product of a great deal of work from Denise Donnelly and Cameron McBean and others on the procurement team. And of course, we will update you on our public listening sessions, which actually kick off next week. And we have some really exciting updates of what is happening on that. Under stakeholder engagement meetings, I'm remembering a comment that Commissioner Choate made at a prior meeting about sharing some of the learnings of our ongoing engagement with stakeholders and other industry actors. So I think what I'd like to do over the coming meetings, whether we're prepared to do that at the next meeting or not, add that as a regular feature of what we're hearing as we engage with our stakeholders and other important partners. So we'll be back to you more on that. Also, in a separate conversation I had with Commissioner Choate, I'd love to take this model. I think the calendar is a great way for us to understand where we are in a broader set of work streams and apply it to our run up to fiscal year 24 and the next procurement. So look forward to seeing in a deck in the near future some more detail about what we envision as being the steps leading up to that next procurement. I do just want to note too here the conjoint survey, which we discussed back in the fall. We had an initial plan to roll that out in I believe it was November or December, and we put that on pause for a temporary period while we do some of those initial stakeholder meetings, which to me felt important to do first. So we had been shooting for a Q1 timeline for that. I think given all that we have leading up to annual enrollment, starting on the 1st of April, I think a more practical timeline for us is to look to Q2. But I want the Commission to hear clearly from me that this is in no way a signal from me or any of us that the survey is not still an important data gathering tool that we will rely on quite a bit. So we are fully committed to do that survey, and we are, there are some time constraints here. We can afford to delay it a little bit, but not indefinitely, because we need those results to inform our upcoming and ongoing, really, procurement discussions for the next procurement. So I'm happy to take questions on any of that before we move on to the next slide.
I don't see any, Matt.
No hands raised? Okay, great.
See
If
any.
you could move on to the next slide, Janine, that'd be great. So a couple of brief updates. Again, we have a heavy agenda here, but I do want to touch on a few items. I want to thank Linnea Walsh in our communications department, working with Erica Schiavelli, our new Deputy Executive Director, for all the work that they are doing on the communication side. With our members. I'll touch on vaccine distribution a little bit later under COVID-19, but we have a lot of work still going on with a Mask for You employee assistance program. So members can anticipate a number of communications from them. There will be a flyer coming shortly about managing financial stress during COVID-19, which we'll be sending out, I believe, today to our partners in government, to our GIC coordinators to pump out to our members. In February, we'll be having some communications around healthy relationships and tips and resources that Mask for You has to navigate what is, to use an overused phrase, a really extraordinary moment for all of us. Finally, Adam Mintz, who's our integration specialist at Optum for the EAP, has scheduled and conducted a number of webinars and trainings and overviews of the EAP services for a variety of our partners in government. So there's a good deal more on the communication side, which particularly around the listening sessions, which I'll have Erica Schiavelli speak on in a moment. But that's it on the communication side. For legislation, we have talked in past meetings about a bill that was working its way through the legislature that did finally make its way to the governor's desk and was signed on the 1st of January. It we provided a summary to the commission in your packet of that bill and highlighted some of the specific items that will impact the GIC, which I'll note briefly here. The ones that were most impactful on us, I'd say, were around telehealth. So it requires a GIC to cover telehealth services if those services are covered as an in-person visit. So this is basically coverage parity for telehealth services. It does allow the GIC room to negotiate, to have our carriers negotiate the rates of reimbursement for telehealth services. Telehealth services cost sharing cannot exceed the cost sharing for a same service delivered in person. So another element of telehealth parity. And it requires behavioral health services to be provided that are provided by phone or video to be reimbursed the same as in-person services. So that's the one area where there is a specific payment standard is for behavioral health services. There are a few other provisions in the bill. There are some mandated benefits that apply to us and the commercial insurance marketplace, and some notification requirements on providers around surprise billing. Of course, we already have surprise billing protections for our members, but so those will apply more broadly to the insurance market. On human resources, I'll just want to say two things. One is to echo my chair's welcome of Emily Williams as our new chief of staff. Commissioners will know Emily from her participation on the commission. She's been an extremely helpful partner of ours, beyond that as sort of our day-to-day liaison at A&F. So she's very familiar with our issues, of course, familiar to you all, familiar to our staff. So I am very hopeful and confident that she can join the team and contribute right out of the gate. It's been a challenging time to not have a chief of staff for an extended period. So filling that hole, I think, will be really helpful to all of us. So Emily brings a great deal of talent and to this team. And I can tell you that she is very well respected among her peers in state government. So welcome, Emily. She may want to say a brief word if we can allow her to do that, if there's no objection.
Thank you, Matt. I know that we have a very packed agenda today, so I'll keep it extremely short. I'm looking forward to joining the great team at the GIC and to helping to continue working on the mission and moving forward and working closely with all of you commissioners in this new capacity. So thanks again, Matt, and thank you, Valerie, as well.
Thank you, Emily. The one other human resources item I want to mention is just of a general nature, but I want to take a moment to acknowledge the entire GIC staff. It's an extraordinary time. Everybody keeps using that word. There's a lot of words we could use, but we have a team that's working at a very high level. And we've, especially now as we head into our super busy season, we have many priority work streams that are operating on all cylinders. But I do want to note, it sounds sort of cliche, but our humans are our essential resource. And there's no way that we'd be able to do without each and every one of them and their hard work and their dedication to craft, really. So I'm really proud of them as a team, happy to be part of that team. But I think it's also really important for me that we not burn out people as well. So there are some features of remote work that can really add an additional layer of stress and pressure on the work that we're doing. And I'm very mindful of that. So I look forward to working with Emily as the new chief of staff and the rest of the management team to make sure that we can really strike the right balance with our staff. So I just wanted to acknowledge that. A brief update on the health benefit procurement consultant RFR, and I may ask Denise to fill in some details here, but we are in the process of bringing on this consultant. I'll remind commissioners that this is the role that Willis Towers Watson plays for us today, and it is wide-ranging from managing the procurement to a variety of other really critical categories of work. And so we as of I think the 19th had the deadline for bids to be submitted. We have a pretty robust response to that bid. Again, our procurement team is digging into that as we speak, and look forward to coming back to the commission as we move forward there with a recommendation. Denise, is there anything else we should highlight in that category?
No, thank you, Matt.
Okay. The Tufts Health Plan and Harvard Pilgrim merger, as commissioners will be aware, earlier this month, there was an announcement by the two that they had completed their merger, which had been in the works for several months. And I want to provide a little report to the commissioners on our activities as they relate to that merger. So I want you to know that I've been in regular touch with the CEOs of both plans, and Denise and her team continue to work very closely with their counterparts at both plans. I have expressed our desire to make sure that however this transaction proceeds, and the integration of the two plans proceeds, that we minimize to the best of our collective ability any disruption on our members. And I can assure you that they share that sentiment and that commitment. I want to assure you, and we are assuring our members, that there will be no changes to their plans that will result from this transaction. Certainly for the remainder of this year, for those who are enrolled in Tufts and Harvard Pilgrim, nor in the coming annual enrollment for FY22. And I would say the same for FY23. So what we have said is that that member-facing changes, we should all be working towards coming together as part of offerings made through the next procurement. Now, that said, these are complex integration projects. And it won't be surprising if some issues arise that have a member impact. We will manage those with the carriers, and we expect and have expressed our expectation for significant lead time on any such impacts on members. So,
Hey, Matt, can you
yes.
just touch on the timing for the combined company, and is there a name change, and did they give you any specificity on how they're going to harmonize benefits and ways they work, or is that too early in the process?
I'd say the latter category is we're not quite there yet. The harmonization of all of their programs, their networks, their vendor relationships, their operating systems, those things will take a good deal of time. That is actually the work that is largely ahead of them as two entities working together. What happened on I believe it was the 1st of January, was an announcement of the creation of a holding company that combines both entities. It doesn't yet have a name. I would expect that in the coming few months. But I've been assured that they will, for all intents and purposes, continue to operate as separate companies for our members through the end of our fiscal 23 coverage.
Thank you.
So in addition to those discussions, I think one could certainly ask for us to peer into the future about what this means for the GIC, for our strategies in the next procurement, and where this combined entity will provide significant new value to our members and to the marketplace. I could share a few observations of priorities that they've expressed to me. Certainly, number one would be, as with any merger of this type, greater efficiency, administrative efficiency, and they've expressed a real focus on affordability as being a high priority. On the kind of non-cost side of the ledger, behavioral health access and integration has been expressed as a high priority and area of focus, as has work on complex care management, telehealth services, and health disparities. I think the combined entity too probably puts them in a good position to create more and more innovative provider contracts, value-based contracts for our members. So that will all be, again, as I said, the work ahead. And I think the Commission can expect for us to be providing you regular updates on this topic going forward. There's a lot there. I'm happy to take questions, but we could easily spend 15 or 20 minutes on this one topic, and we will have further discussions on it.
Okay, I don't see any questions, Matt. I do think there's definitely interest, especially for our members, for any kind of disruption they may experience. So keep us posted.
Great. Finally, before I turn it over to Erica to walk through a little bit of what we've done for the listening sessions, public information sessions, a touch on COVID-19. And here I want to touch on two items. One relates to vaccines. So we have been getting some inquiries from our members into the operations unit about when and how they will have access to vaccines. We have been assuring them that their vaccine will be covered in full. As I've mentioned at the last meeting, the federal government is covering the cost of the vaccine itself, and we have directed our carriers to cover the administrative cost in full with no cost sharing for the members. For our non-retiree active plans, the vaccine will be covered under their pharmacy benefit, so through Express Scripts. And for our Medicare members, the administrative cost is covered under Medicare Part B. So we've provided some talking points to the Public Information Unit about vaccines so that they can answer those questions. We are, as it relates to when and how people get vaccines, of course, looking to our partners at DPH and EOHHS and the COVID Command Center to guide our members in that regard. I will remind members that our instruction to the carriers for no copays for any telehealth services continues in place through the end of March. And we will evaluate the need, if we have one, to continue that instruction. And I will say around vaccines, we do have some very limited early data about the number of our members who have received the vaccine. A little shy of 300 of our members, we have received claims that they have received the vaccine. I expect that that understates the number that have received the vaccine. I see Commissioner Murphy-Rodriguez nodding her head. I suspect that a good number of the first responders who are covered in the GIC through our municipalities are receiving that vaccine through other means, and we may ultimately see some claims that come to us as a result of that. Interestingly, the Pfizer vaccine is by far the predominant vaccine that our members have received. 274 of those, just a dozen or so of the Moderna vaccine. That's my vaccine update. I want to pause there. I suspect commissioners may have questions or thoughts on the vaccine.
I don't see any questions, Matt.
Okay.
The only comment I have is let's go.
Yeah.
So thank you for all the work that's being done to get our constituents and our members vaccinated.
Thank you for that. The one last thing I'll note here is that part of our collaboration with our partners in state government will be addressing vaccine hesitancy, which we know is a substantial issue as it relates to this vaccine. So we will be using our communications channels and tools to encourage our members to get the vaccine and to assure them or reassure them that it is safe, it is effective, and it is really something that everybody should get as soon as it's available to them. For the last item under COVID-19, I want to turn it over to Cameron McBean on Denise's team to discuss some new steps that we've taken recently regarding health savings account and the flexible spending account to provide greater flexibility to our members to spend down any balance that they still have. This is flexibility allowed by the federal government, given the depression of utilization in healthcare that we see as a result of COVID-19 that would otherwise put members in a position of losing a substantial portion of their HSA balance. So I wanted Cameron to provide a few details on that. Cameron?
Sure. Thank you, Matt. Good morning, commissioners. As you may know, as part of the original CARES Act relief package, we made some adjustments to our grace period, extending them for the fiscal year 20 participants in both FSA plans. And buried within the 1,300-page Consolidated Appropriations Act that was passed right around New Year's, there are additional relief measures that will be able to allow particularly fiscal year 20, the prior year participants, an opportunity to spend down remaining unused funds. We have further extended the fiscal year 20 grace period as a result through the end of this current fiscal year, so through June 30th. And the dependent care account funds, if you were a fiscal year 20 participant and you had a child who is turning 13 during this current year, you will still be able to use funds from your DCAP account for expenses on those children. There are also some changes associated with the current year participants. We're allowing for changes to elections on both the dependent care and healthcare FSA plans without a qualifying event, although you can't backdate and get a refund for contributions made to date. Unless you have a documented qualifying event. And then there are also some changes allowing for utilization of funds if a employee terminates employment during this year. These are all in direct response, not just to what was allowable within the recently passed act by Congress, but also they address some member complaints and feedback that we've received as folks try to utilize the full extent of their FSA balances. So that's a very high-level summary of the changes that have been implemented. We had to move quickly on this because under the previous extension of the fiscal year 20 grace period that ended on December 31st, and January 31st had been the filing deadline. So the coordinators have all been notified. Emails are going out this week to anyone with a remaining fiscal year 20 balance, notifying them that they will have further opportunities to utilize those funds. So that's my high-level summary. If anyone has any questions on this matter, it looks like Bobby.
Yes, I do. Thanks. So I just want to ask, when you say the funds can be spent down through this year, do you mean the fiscal year, right? You mean to
Correct.
June 30. So that, high level summary, can you provide that in writing, all those points that you mentioned, including, the DCAP information? Would you be able to provide that to us in writing? Because
Absolutely. It's also already available on the Benefit Strategies website. So any participants are welcome to go there, and there should be a link that's fairly obvious when they sign in to the Benefit Strategies GIC microsite.
Okay.
Bobby, you raise a good point. I think we can, we should take back the idea of kind of putting together a bit of a communications plan for this. I think this should probably be something that we note on our website and push out to our GIC coordinators to share with their members, and of course, look to our stakeholder partners such as yourself to help us get that word out to our members. That's an important new development that we should make sure that members are aware of.
Right. Yeah, I'd appreciate that because I want to be able to post it on our website and also get it out to members.
We also plan on incorporating it into the annual enrollment communications.
Okay, great. But it would be good to know like now because it's January. Right. So that would be terrific. Thank you. I appreciate that.
Matt, Liz Shabbat, I just want to second what Bobby was stating, and putting that on the website is very important for our members. It will cut back with all the phone calls and the questions. It will be bullet points so they don't have to go and look for more information, particularly when they have children and there's so much going on right now.
Yeah.
So thank you. Good point.
Thanks. Further comments on this or any other item here? We are already running up against our a little over our allotted time, but I do want to turn it over to Erica to give us a little bit of an update about next week's listening sessions. We've had some pretty mind-blowing response to our virtual listening sessions, so some good news to hear there. Next slide, and Erica.
Good morning, Matt. Good morning, Madam Chair and Commissioners. So as Matt mentioned, we do have a pretty great response rate for the webinar sessions scheduled for next week. So as you can see on the slide, we have 4 sessions scheduled at a range of times to accommodate different schedules, including a Saturday. At the last meeting, Vice Chair Kaplan mentioned that she'd like to see a lunchtime date and time. I think that you were onto something there because that is by far our biggest registration. So I can give you the numbers quickly there, and then I can talk to you a little bit about the communications that we put out to get us to those numbers. So for our first session on Tuesday, we have 389 individuals signed up, and this is just as of this morning at 8:30. The lunchtime session, we have a whopping 836 folks signed up. For the Thursday session, we have 178, and the Saturday session, 180, and that gives us a total of just under 1,600. So that's a really massive response rate, and we're really excited about that. What I'm told is that we don't usually get that many. So as this is my first go around here, I'm really excited about it. So we have sent out a number of different communications. First, we sent a postcard out to around 239,000 subscribers. So you should be getting that in the mail if you haven't already. And then we also have sent out a series of email blasts. The emails, I believe we sent around 143,000 email addresses that we sent to, and we had a response rate or an open rate of 32%, which is pretty big. So we're really excited about the attendance rate. Looking forward to hearing from folks. I'll be following up with those who have registered to determine who wants to speak and figuring out the kind of the order in which that will go. If folks still want to register and they haven't yet, you can go to mass.gov/group insurance commission, and there will be a banner at the top of the page that you can click on, and it will bring you right to your registration links. And so please just register for one session only. As you can see, we have one session in particular that's really popular. But we have lots of room in all the sessions. And just a note that participation isn't required here if you want to participate in annual enrollment. Just want to make sure that there isn't any confusion there. We would love to have you if you'd like to participate, but it's not required. And we'll also be accepting any comments for those who can't attend at gic.info at mass.gov. So please feel free to send comments there as well. And that's what I've got for the update.
So if I could just make a couple of points. One, I would really encourage commissioners, if you can make time to attend one of these, to please do so. And if you do that, to please let me or Janine know so that we can acknowledge your presence on the call. I've attended these in the past when I was a commissioner and always got a great deal out of doing so. I do want to note that the deck that we will be using to kind of lay the groundwork before we open it up for public input will be available very shortly, probably by end of day today on our website, and available for viewing. I know the commissioners have expressed an interest in us making sure that we do that. As Erica noted, we will also have, we do have the capability of receiving information by email. Thank you, Commissioner Sullivan, for pointing out that we neglected to include that on our website when we first put it up, but we have since put that up. So we're trying to give as much opportunity here for folks to weigh in as possible. And clearly this will be a feature even after COVID that we will maintain this virtual format, because it clearly has some interest on the part of our members. I'll stop there and take any questions.
I think Bobby has a question or a comment. Go ahead, Bobby.
Yes, I do. So I've received a few emails from people who actually were not happy that we only had one session during the workday, during work hours. And a couple of people said, actually three, said that they tried to register for the lunchtime session and it was all full. So I don't know how that could be, but so I just wanted to raise that. I don't know if anyone else has heard, and if it were possible to have another lunchtime session. Do you have any idea, Erica, how many, like, is there a wait list for the lunchtime sessions, or do you know?
There isn't actually. We do have a limit of 1,000 per webinar session. So with the 836 individuals that we have signed up for lunchtime, there is still plenty of room. I would be happy to connect with whomever reached out to you to make sure that we can get them registered, and I can certainly do that on the back end here. So I'd be happy to connect with you on that.
Oh, okay. I'm going to ask them to, to try it again,
Sure.
Since there are fewer than 1,000. So I'll ask them to try and then see if they have a problem. Okay. So thank you very much. Thanks.
No problem.
So I have a question on logistics for the recording. So we have 4 sessions. Will all 4 be recorded, or will just one be recorded and posted on YouTube?
They'll all be recorded and posted.
Okay, great, thanks. That's terrific. Well, in the interest of time, I don't see any other questions. So I am excited about the recording and the virtual sessions. Sometimes we can see good things that have happened from our virtual world that we're living in now. So this is one of them. And so thank you to the staff for making this happen so quickly. So let's move on if we can.
Yep. Thank you, Madam Chair. So at our last several meetings, we have provided as a regular feature a COVID-19 data review about the impact on our members, insights that we can glean from our claims database. We are currently, as part of our transition from Optum to Milliman on the database, limited in our ability to draw on the database for those sorts of data. But we did want to continue the discussion here, particularly since the discussion about COVID's impact on our FY22 rates was such a robust one at the last meeting. So we invited Jeff Levenshires, our partner at Willis Towers Watson, to run through a couple of slides here about the variety, the wide variety of sort of puts and takes to costs that results from COVID-19, and to have a little bit of a discussion on that. So with that, I'll turn it over to Jeff.
Great, Matt. Thanks. Thanks very much, and very nice to see committee members this morning, commission members this morning. So I want to maybe start by just a reminder about how, and maybe move on to the next slide. Start with a reminder on how we generally look to project claims costs for the following year, and claims costs obviously lead to what premiums are. So generally, we have actuaries. Vince Kane is our senior actuary, and does this really for much of our whole company. The actuaries look at the previous few years. They see what they see what the pattern is, and they project completion for whatever the current period is. Then they make estimates about what's expected to change. So, for instance, if there are new provider contracts, that might increase unit costs. If there have been a bunch of new hires, that might decrease age, that might decrease utilization. And put all this data together to model what the claims cost would be the next year. That determines the premiums. Fiscal year 22 is obviously a huge challenge because it's unusual. The pandemic had a huge impact on claims costs through calendar year 20 and for the GIC fiscal year 21. So this past year is a much less reliable base to make estimates of the costs for fiscal year 22. So I think from the last meeting, there was a perception that we just sort of decided to ignore the pandemic year. And I just want to explain that's actually not the way we approached it. What we did was we considered a series of possibilities and actually arranged for each of those possibilities and tried to figure out whether each of those would increase or decrease the cost in fiscal year 22. We've also had a chance since then to look a little bit at what happened over the summer with real-time claims costs, given that the spring was a very bad time, and then the summer the pandemic actually ebbed substantially. So we did see partial return of services, and it gives us a sense about what will happen as hopefully we exit the pandemic. Sometime in late calendar year 21, the one we're in now, or hopefully that is the case anyway. So first, and I'll sort of go through this, but maybe not exactly as it's on the screen. First, there's the duration of the pandemic. So what we've learned is the pandemic paradoxically lowers the total cost, that even though there's terrible tragedy in all of the illness, and there's actually very high costs for people who are desperately ill, the amount of care that didn't get delivered to other people was actually represented more dollars than the dollars to care for people with severe COVID. So to the extent that the current that we are more effective at ending the pandemic sooner, that will probably mean costs will be a little higher than if the pandemic ends later. Then there's the whole question of pent-up demand. So many of the things that people didn't get during the peak months of the pandemic, they really needed and they were going to get, they just were going to wait a little bit. So for instance, and it's pretty terrible, there are people who had cancer and didn't get their cancer removed for a number of months because hospitals were so overwhelmed with COVID. That's still going on in the Southwest right now. So those surgeries pretty much all happen. They just happen later. Then there's some surgeries that happen later, but they'll actually come back more slowly. People who, for instance, need knee replacements, it's bad to wait too long, because then then you get deconditioned. It's much harder to rehab. But it's but people wait longer, and then there are a lot of services that simply never come back. And so, for instance, I do a little bit of urgent care. So all of the self-limited disease that I used to see in urgent care, people are just staying home with that. They're doing telemed and whatever, or they're doing nothing. And those services will never come back. And also, the longer the pandemic lasts, the less likely that certain elective procedures happen. So for instance, there's very good data from the UK in the 1980s, when there were very long lines for elective orthopedic surgery, that if people waited on a queue for 2 years, the majority of them ended up dropping off the queue. So anyway, there's pent up demand. There's obviously been a huge change in preventive care, and a bad change. So the fact that a lot of kids didn't get vaccines, we're hopefully recovering from that, especially in Massachusetts, but that's going to actually lead to more medical costs. Vaccines actually save money compared to most other things in the medical world that don't. Screening means we probably will have some cases of cancer that are detected later. I've actually heard from a colleague in pediatric oncology that they're actually seeing much later diagnoses, because kids aren't getting their abdomens palpated by pediatricians, and so their Wilms tumors are being found later and things like that. So there will be some increased cost, but on the other hand, generally this kind of screening that we do, like mammograms and colonoscopies and pap smears, they actually save quality adjusted life years for a reasonable cost, but it still costs. So anyway, preventive care, this will probably be offsetting. On the pharmaceutical side of things, there's the cost of new COVID meds, especially the new rheumatoid arthritis monoclonal antibodies, which look like they're effective for pretty ill people. They cost $10,000 or $12,000 a person. That will matter. There'll probably be fewer new pipeline drugs, just because the pharmaceutical companies have been so busy with COVID. There's the whole issue of burden of illness. So there'll be some worsened chronic disease. On the other hand, it's terrible, but COVID mortality has been very high for people with certain chronic diseases that are very expensive, like, for instance, people on dialysis. One thing that we see in terms of raising costs in the future is that mental health has actually suffered dramatically during pandemic and during lockdown, and also with the kind of losses people have had that have been very hard for them to cope with and to deal with in a normal way. And then maybe the last thing to mention in this is that what providers do really matters. So there's been a lot of loss of revenue for providers, especially on the ambulatory side. There'll probably be a lot of consolidation that will tend to raise unit costs. Some providers will actually be looking to make up for lost revenue. They've already got these expensive machines. They haven't been using them for a bunch of months. Now they'll want to use them more. Virtual care could sort of run two ways, and I have a little bit more on this in the next slide. But on one hand, virtual care should lower costs, because even if people get more of it, they're not, if you're having a virtual visit, you can't get x-rays and ancillary tests, laboratories and things. So they should probably lower costs. On the other hand, it might be that, after the pandemic, people will keep on using all the virtual care, and that'll just be an addition to going back to all of the regular care that they got. So essentially, when we put this all together, we think that all these puts and takes mean that it's most likely that the trajectory of cost for fiscal year 22 will be pretty similar to what it would have been had there not been a pandemic. Now, because there's so many more moving pieces this year than there are in most years, and so many assumptions that we have to sort of make, there's probably a little bit larger confidence interval. I mean, there's a bigger chance that we'll be off by a bit, but we actually have been thinking about each of these different things. And the second page, just to sort of give you some metaphors. I mean, there are things that got hoarded early on in the pandemic, like to some extent like toilet paper. You just only use the amount you use. And we saw that actually in pharmacy, where a lot of people moved to 90-day mail-in prescriptions. And so you saw actually a pretty big spike in March in pharmacy costs, and then a somewhat lower amount of cost later on as people sort of use those medications. There's stuff that you need pretty much regardless, where nothing really changes. There's stuff that you sort of, I don't know, my iPhone, it's got a cracked screen. I could use a new one, but on the other hand, for $1,000, I could wait a little while longer. And that's things like joint replacements, where, the cost during the pandemic will go down. The cost after the pandemic would go up. Net over multiple years, it'll be less cost because some will be missed. But you should expect that in fiscal year 21, the cost would be sort of what it would be otherwise. Haircut, I pretty much terribly need one at this point. But if you don't get a haircut for a while, you're not going to go get a whole lot of extra haircuts afterwards. You're just going to go back to what you were on before. And that's things like preventive care, where if people are a year late for their colonoscopy, they're just going to reset to being a year late. There won't be extra costs later. Bottled water, that sort of stuff, which is you could actually drink from the tap, at least here in Massachusetts and most of America most of the time. And so basically these are things like healthy annual physicals for young healthy people, some in-person visits where it could have been done with just a quick virtual check-in. And those will probably keep on lowering costs later to the extent people get used to them. Although, as I pointed out, the digital wallet thing, sometimes if we make virtual care so incredibly easy, but the providers continue to provide all of the in-person care, we could end up with somewhat extra cost afterwards. So obviously, prediction is not a perfect science. There's the Niels Bohr quote. It's very difficult to predict, especially the future. So things will not work out exactly as Vince and I and a bunch of senior actuaries are saying. But we think that when we add all the different moving pieces up together, we're likely to end up with something where costs in fiscal year 22 are similar to what they would have been in an alternate universe that all of us would rather inhabit, where there had not been a pandemic. So happy to take questions if there's time, and appreciate the opportunity to go into this a little deeper.
Thanks, Jeff. I'm always super interested in the data that you present, so thank you. I don't see any questions, but I do think this is quite informative. So appreciate your presentation and your perspective.
Thanks.
Matt, I'll turn it back over to you. Maybe get us on track for time.
Yep. Janine, if you can take us to the next slide. So here we're going to move into two of the kind of meaty items of the agenda. Not to say that a COVID data review is not meaty, but I want to start off with a discussion about the FY22 plan design. So if you can move to the next slide, Janine. So commissioners will recall that when we met in December to review the initial projected aggregate increase in rates for FY22, that we had a request from the commission to come back with potentials or options that could be evaluated around plan design to help mitigate that increase. So we've, our team, Denise's team, has worked closely with the folks at Willis Towers Watson to evaluate 4 potential plan design changes. We'll remind commissioners what we have often expressed as a group is a preference to avoid significant plan design changes while we are in the middle of procurement, and to minimize disruption for our members outside of a reprocurement. And our sense here was that concern around disruption is really only heightened with the pandemic that is upon us. So we will be presenting 4 changes. I do want to note here that 3 of the changes do produce higher cost sharing for our members. We are not recommending that the commission proceed with those. And I will note here too that we are not making any changes to the Medicare supplement plans, although it's important to remind folks that some changes to the Medicare plans could come about as a result of changes made at the federal level. So before we get into more on this, I do just want to note that the rate of increase in our premiums that we've projected at the last meeting still has to be very much in the forefront of our minds as a challenge that we need to tackle. I think what you will see highlighted in our evaluation of these options is how much of a challenge it is for us to have substantial downward impact on premiums that we can make in the midst of our procured contracts with the carriers. And it really does point to our coming procurement for the health benefit as the real strategic opportunity for us to address what are really some troubling trends. We had several years of flat increases. We saw those creep up over the last couple of years. Last year, we got up into the territory of 5+% increases, and we're seeing more of that this year. So I think this is the appropriate approach from our perspective that we want to recommend, given COVID-19, is not to make changes here. But I think we can't lose sight of the fact that there still is an urgency for us to address underlying costs, which, if they continue at a rate in the 5s, is really unsustainable. So we need to keep our eye on that ball. Move to the next slide, please. So we are not, as you can imagine, proposing any changes here based on that setup for me on the carriers that we offer or the products they offer. So you'll see the same 6 carriers and the same 11 plans. Next slide, please. So as always, we use as a resource the good work at Willis Towers Watson to analyze the degree to which we track with our benchmark comparators as it relates to plan design features here, and those areas where we may be an outlier. So you'll see in many cases we are aligned, but in a few cases we are a little bit richer than our comparators. So those point to some opportunities that we've modeled going forward. Next slide. So I think this is where I'm going to turn it over to Vince Kane at Willis Towers Watson to run through the details of each of the items here that we have analyzed. Given our recommendation that we not proceed with items 2 through 4 here, I think probably we don't need to go into significant detail on those, but I do want to give the commission a sense of what we looked at and what we found. So with that, I'll turn it over to Vince.
Yeah, and the only thing I would add, Matt, is, or Vince, as you go through it, what could be the potential savings to the state and to the commission, just to make sure that's part of the view that you give to us. Not that we have to go into detail, but it would be interesting to hear that and what that impact might be.
Great, thank you. And we do have that information, so we can share that as we walk through each of these 4 options. At a high level, and we'll have a slide on each one of these, the first sort of plan design change, which is a benefit improvement, is to waive the cost sharing on behavioral health televisits for a certain number of visits per year. So we chose 3. And, obviously coming out of the pandemic, we expect there to be a need for behavioral health care and increased access, and removing the copay is certainly a way to encourage utilization and remove one additional barrier to that care. The second one is an emergency visit, emergency room copay increase. So the plans for the non-Medicare folks have a $100 copay today. And we'll walk through some of the details around utilization for GIC specifically, and the potential savings for increasing the copay to be something closer to benchmark. And that would only be the case where folks are not admitted. So folks who have a true emergency, that copay is typically waived anyways, whether it be $100 or $200. The third change is a deductible increase, which would apply to the family tier only. So today, the deductible for an individual is typically $500. Some of the plans are $400, and the family deductible is 2 times that amount. So the proposed change would be a 3 times multiplier, so increasing that to $1,500 or $1,200, depending on the plan. And the last change, which was evaluated, was a coinsurance. And this is a fairly significant one, as there's no coinsurance today for services after the deductible for which a copay applies. So this would apply a 10% member cost share for any services after the deductible for which a copay does not apply today. And, again, numbers 2, 3, and 4 aren't really on the table, but we're presenting them as options, and we've evaluated the financial impact for FY22. Next slide, please. And the next slide. So the first one, which is an additional cost, basically moves everyone for the first 3 behavioral health televisits from a current copay, which averages $15. It actually ranges between $10 and $20, depending on the plan, and removes that copay for members who engage with their behavioral health provider in a telehealth setting. So the cost for that is about $1.5 million. It's expected to impact about 40,000 members. So that's about 12% of the non-Medicare membership, which is over 300,000 members today. And these savings were estimated in collaboration with the health plans. We reached out to each plan specifically, since they have data on the utilization profile of the members enrolled in each of those plans. And we're poised to give us an estimate for what they think the impact would be for FY22. So on the overall rate increase, this is pretty immaterial, but it will be an additional cost. I think it'll be less than 1/10 of a percentage point on the total expected average rate increase if this were to be voted in.
Thanks.
Next slide.
No, before we move on,
Yep.
Bobby, do you have a question?
Yes, I just have a question regarding the 3 free or no cost visits, because EAP offers 3 no cost visits under EAP. So my question is, if someone has 3 no cost visits through EAP, and then they decide to sort of connect with a different behavioral health therapist, would they be able to receive another 3 no cost visits?
Yeah, I believe the intention would be it would be additive, so it would be an additional benefit. But if that's not true, perhaps someone at the GIC could.
Yeah, no, I can confirm that, Bobby, that those 3 copay-free visits with the EAP will still remain, and this would be on top of that.
Thank you.
Thanks.
Next slide. The next one. So for emergency room, we did an analysis, and we have data on the next slide to show you the amount of dollars that have been classified as avoidable or potentially avoidable based on a 12-month view of the GIC members' emergency room utilization. That in addition, the higher benchmark average ER copay of $150 might suggest that there's room to increase the copay at some point in time to mitigate some of the avoidable utilization and steer it toward a better side of care, for example, urgent care. So we reached out to the plans and we asked them to quantify the impact of increasing the copay to $200. This was more of a sizable savings. It's 7.9 million. The plans and their actuaries looked at assumptions around a utilization reduction, which on average was about a 5% expectation for increasing the copay. But in addition to that, there was a substitution effect where a portion of the visits that are reducing are really just moving to a cheaper site of care. This change would impact a lot of members, over 14% of them, 45,000. And again, we're not recommending this as a plan change for FY22. Next slide. So the benchmark sort of ER rate across the IBM Watson Health Market Scan database is 231 per thousand. The median's 222. So when we looked at the GIC non-Medicare population, it was higher. It's about 250 visits per thousand for a total of almost 80,000 visits over a 12-month period. Next slide. When we further tried to use an algorithm from NYU to classify the visits based on diagnosis information and other groupers as potentially avoidable or avoidable, we found that there was, in fact, a portion of the dollars attributed to that ER visit rate of 250 per thousand that were classified as avoidable. And that was, 14% of allowed spend. It actually ranged quite a bit. And range from 11 to 16%, depending on the plan. The potentially avoidable spend at 19% range from 17 to 21% based on the plan, and the overall totally potentially avoidable spend of 33% range from about 30 to 36. So not a lot of variation in those metrics by plan. The algorithm from NYU basically classifies avoidable spend as non-emergent. And I'm quoting directly from their algorithmic logic and the patient's initial complaint, presenting symptoms, vital signs, medical history, and age, indicated that immediate medical care is not required within 12 hours. So that's the definition of non-emergent care. For the potentially avoidable category, that's actually what they call emergent or primary care treatable. And so based on information there, treatment was required within 12 hours, but care could have been provided effectively and safely in a primary care office setting. And the complaint did not require continuous observation, and no high-cost procedures would have been done like CAT scans or immediate lab tests that would not have been able to be performed in a primary care office setting. So, given that category and the fact that the algorithm doesn't look at day of the week because you can't go to your office, your typical PCP office on a weekend, that might be an upper bound. However, this is dollars, and we'd probably see that the visits that are considered avoidable or potentially unavoidable are less costly. So it's likely a higher percentage of visits that would be classified as avoidable, based on the data that we pulled. Any questions on emergency room?
Maybe we take questions at the end is my suggestion.
Okay, next slide. And the next one. So the deductible change, today with the family contracts, the family deductible is a 2 times multiplier. So in the event that you have single coverage, it's $500. In the event you have family coverage, it's $1,000. So this would propose moving that multiplier to 3 times. So it really would only impact family contracts where there's more than just an employee and covered spouse. You'd have to have a third member, accumulating toward that family deductible. Given the data that the health plans looked at and the number of family contracts that were already pressing up against the family deductible and the composition of dependents per family contract, the number of impacted members is under 30,000, which is less than 10% of the total members. The savings potential here is similar to the emergency room copay at $7 million. Next slide. And the last one is fairly significant. This is again applying coinsurance, which does not exist today, any of the GIC non-Medicare plans. The benchmark from the Willis Towers Watson database had coinsurance around 80%, and for government and public entities at 90%. That is the member paying 20% or 10%. So implementing a 10% coinsurance for the services for which a copay does not currently apply and that are covered at 100% after the deductible today would produce sort of an upper bound of a little over 50 million. There's some caveats there. We got some different responses from the health plans around what was administratively or operationally feasible. And there was not total consistency across the service categories for which the coinsurance would apply. Examples would be sort of, diagnostic, X-ray and lab, specialty drugs on the medical side, which can be very costly, emergency transportation, durable medical equipment, and the list of services that's more exhaustive. That's probably in the benefit plan description. So the impacted members here would be significant. The counts that we got from the health plans were not necessarily unique because there's multiple service categories where coinsurance could apply. But we'd estimate that 70 to 80% of members would potentially be impacted by coinsurance, as outlined here. So that's it for this section. Are there any questions on the 4 plan design changes that we presented today?
Go back to slide 25, Janine. Just keep that up actually go back again to one of the tracking slides. Perfect. Thank you. Thank you, Vince. Turn it over to you, Madam Chair, for discussion if others have their hands up.
I don't see hands up. I do feel that it's good work, as always, by Willis Towers Watson. So thank you, Vince. It feels like we're just nibbling around the edges, and that's a term you used last meeting. In this environment, it doesn't seem like there's value in making changes to our members. At the same time, we're all respectful of the astronomical increases in premiums every year that are picked up by the members, but also by the state. So I know this is a consideration, but at this point, I don't know if there's value in exploring these increases to member out-of-pockets now. I don't know if others, it looks like Christy has her hand up. So why don't you go, Christy, and then Bobby.
Thanks, Valerie. My question is really more going forward when we look at the next procurement, this idea of charging it really going away from any family deductible and instead just charging the individual deductible for each person that's covered. And if that's something that we've ever looked at before.
Yeah, I believe I can begin to answer that. The way the family deductible works today is it's an embedded sort of individual deductible. So for example, if it's 2 times the individual deductible of 500, that means once one person satisfies 500, they're done in the family contract. A second member would then need to satisfy the 500 for a total of 1,000, or multiple members would accumulate toward their own sort of deductibles until the overall amount accumulates to the 1,000. So in a way, there is sort of a individual or member specific deductible accumulator, but each of those amounts, once they hit the effective embedded deductible, which is 500 today or 400 for some plans, then you move into 100% coverage or copays.
Thank you for that, Vince. That is certainly an idea that we can add to the list of items that we will evaluate as we head into the next procurement. I think we want to be mindful of the differential impacts, right, among our members. With any change of this type, it could have, a sizable impact on a subset of our members, right? So there'll be, so we'll need to be mindful of what those impacts are. But thank you for raising that.
Go ahead, Bobby.
So first of all, we, or at least I am, and I'm quite sure that my commissioners, my fellow commissioners who represent union members very likely feel the same way, which is that it's the out-of-pocket, the increased out-of-pocket expense, which I am inherently against, right? If there's an increase in premiums, that increase is not only a pre-tax benefit, health premiums are pre-tax benefit, but they are spread out over a 26-week period, and they never go into the employee's pocket, right? So it's certainly is a lot better than someone who is paying an additional copay for the ER, particularly when urgent cares, close at 9 o'clock at night. Many are not open on the weekends at all, or their hours on a Sunday are reduced to 5 o'clock. And how does the layperson, the average person, know whether it is in fact an emergency? So if you cut your finger while you are preparing dinner and the blood is pouring out, like, how do you know that you don't need stitches? And many urgent care facilities don't even have X-ray equipment. So urgent cares, although great that we have them, are not, they don't have all the equipment or care necessary. And the average person has no idea whether it is a real emergency or not. And so if it's based on whether someone's admitted or what the diagnosis is, all the other factors that have a significant impact are not considered. And I would like to ask, I know I've asked this in the past, but I'm sure the demographics have changed. How many of our members are basically individual, have an individual plan? How many are a two-person, and how many are more than two? Not just percentages, but I would like to know what the number of households are. Because often, the family who has more than two people, in other words, children, often those members are least likely to afford changes. So those are and co-insurance. Co-insurance, I'm inherently against a co-insurance, because obviously, even though the GIC does not recommend any of these changes for FY22, now that they are actually out on the table in the public sphere, that tells me that one of these or all of these are going to be considered in the future. So that's going to be something for obviously future discussions, even if it's not considered for the next fiscal year.
Thanks, Bobby. Tim, you have your hand up. Why don't you go ahead, please?
I would just say I agree with what Bobby has put forward. When I look at cost increases or cost shifting, whatever, I always keep in mind the range of salaries of my members. And I have some members, such as education support professionals, who these types of increases, and I know, Matt, you mentioned a little bit about that, could be devastating. And I don't want to have anything that is going to say to one of my members, I can't afford to get the care that I need because of these types of increases. So I think we have to really be cognizant of the levels of our salaries, and that we do have, these are municipal employees, state employees, whose salaries are not necessarily that of the private sector. And we need to really keep in mind what is affordable for them and what isn't. And I think some of these things that are mentioned here, and I'm glad to see only number one is on the table for today, because I think the other three could be devastating for some of our members.
No, I think that's well said, Tim, and all of us do care deeply about making sure that our constituents get the health care they need. So we're all cognizant of that. I would like to encourage us to get that conjoint survey out, because there may be members who are younger or are more innovative or forward thinking, who may choose lower premiums over coinsurance, or they do maybe view different options differently. So I am eager to see what our survey says and to tailor our needs across the wide swath of constituents we have. So it's just, I think we want to be informed with data from our members, and maybe even at the listening sessions, we can encourage all of our constituents to give us their information so we can include them on the survey. Liz, do you have a question? I don't see your hand up.
I did have it up. Yes, thank you. I have to reiterate what Bobby was stating and what Tim was stating. I have a wide variety of members at different levels of pay as well. Young families, I have people that are retiring. So all of these are big concerns. The emergency room visit, the increase there is a big concern. The out of network is a big concern. So I appreciate this conversation and having really open and honest dialogue about it. But when people ask, what are your concerns? Those are the poignant concerns. And those are the big issues for many families that are struggling right now. So I appreciate this. And I have to say, I'm on board in solidarity with my other labor union members. So thank you.
Go ahead, Anna. I see your hand up.
Yeah, thank you. I appreciate the start of this discussion, and I just wanted to make 2 points. One is that like when I think about insurance, really one of the great most valuable features of insurance is to provide protection against large losses. And so when you think about different forms of cost sharing, like coinsurance really sort of hits at that risk protection much more dramatically than copays. So having no out-of-pocket cost limit, or having members be responsible for coinsurance, is potentially much more harmful in the form of putting people at risk of large losses. Let's just say that. And so I think that whereas raising cost sharing, like in the form of copays or a little more deductible, that it's just less of a hit, and it also is more predictable. And so from an insurance perspective, at least as an economist, that makes more sense. First dollar charges make more sense in terms of risk protection than coinsurance. The other thing I would say would just be to echo Valerie's comment about the conjoint survey and getting some perspective from members about the trade-offs that they would be willing to make, because it may be that people are very willing to have a more limited choice in network, or to choose their healthcare system up front in order to prevent out-of-pocket costs down the road. And it would be helpful to know sort of not only how they would trade off within forms of cost sharing, but how they would trade off, network choices, access to a wide network versus more limited network relative to increased cost sharing, because that can be another way that we could think about changing benefits and also keeping cost sharing down if people are willing to think about narrower networks.
I mean, Matt, do we need some sort of a vote or a motion to not move forward for this season of benefit design for 2 through 4, or can we put this to rest for the rest of the year in terms of 2 through 4 aren't going to be acted on? I mean, do we need a vote, or what's your thinking? Because I'm hearing loud and clear for right now, these might not be, these aren't recommended and nor desirable.
But we don't need a vote today, Madam Chair. Our plan was to gather feedback today and come back to the commission at our next meeting for a vote. We haven't prepared a motion of any type. It's certainly the discretion of the group if they want to offer one that we've not written, but I think my recommendation would be for us to take back the feedback that we've gotten, which is pretty loud and clear, and come to you at the next commission meeting after the listening sessions with a recommended path forward here.
Okay. That's fine. I just want to make sure that we don't reiterate and spend time on a discussion that, to me, I'm hearing loud and clear across the board, doesn't warrant too much more discussion, if at all.
Yeah. Thank you, Madam Chair, and thank you, commissioners. That was a really helpful discussion. Thank you very much.
All right, let's move on in the interest of time, so thank you.
So this will be our one vote for the meeting. And so I'm going to hand it over to Cameron McBean again, Manager of Health and Ancillary Benefits. I want to thank Denise Donnelly, Cameron McBean, members of the procurement team here who have put a lot of work into this. We have presented to the commission our confidential report, which we shared with you all last week. I hope you've all had a chance to read that. I would take an opportunity to remind commissioners that we have to avoid talking substantial details as it relates to particular respondents and how they scored on items in the procurement, so as not to undermine our ability to negotiate a contract that is to our benefit. So just that reminder, as always, when we have these discussions. With that, I'll hand it over to Cameron.
Thank you, Matt. All right, as a quick bit of level setting, just to remind everyone the current status of the life and long-term disability policies that we have in place. The Hartford is our life and accidental death and dismemberment provider. They're in the final year of their 5-year maximum contract. Unum is in the 4th year of its contract as our LTD provider. Boston Benefit Partners was the consultant that helped us conduct this procurement, and you can see a timeline of the process on the bottom of this slide, but I believe we can move on to the next one. So we took into account a number of considerations during the procurement process. We combined both life and LTD into a single procurement because there is interplay between the two in what's known as a waiver of premium situation. So if somebody becomes eligible for long-term disability, their need to continue paying life insurance premiums is suspended. That's what waiver of premium is. So the possibility of moving to a single insurance carrier for this offers some administrative streamlining opportunities. We also took into account a couple of potential long-term disability design changes to account for the fact that the Massachusetts Paid Family and Medical Leave Act is effective as of this month. When looking at that, we decided not to recommend any plan design changes because there were certain circumstances, particularly for higher earning individuals, where if we were to extend what's known as the exclusion period, the waiting period before long-term disability benefits become payable, some individuals would have received less income replacement through PFML than they would have through long-term disability, and the cost savings in terms of premium were very minimal. So next slide, please. So as a result of the procurement process and all the different considerations that we took into account, we are recommending a change of carrier for both of those product lines. MetLife is our recommended provider. They are currently our dental carrier for both active and retirees. And with this move to MetLife, we have seen a reduction in premiums that is particularly skewed towards older employees who generally see the highest premium rates for these product lines. We'll also have those waiver of premium administrative advantages that I mentioned before. And during the interview process, we spoke with all of our finalists about possible solutions to what is, quite frankly, a relatively inadequate basic life benefit that is legislatively mandated and just has not been updated over time to account for, what the basics of a funeral cost. So the state's mandated basic life benefit is $5,000. And so we've had discussions with the Retiree Association and about this topic, as well as just wanting to provide a more valuable benefit offering for our members. And MetLife seemed to have both a very solid understanding of the constraints and challenges under which we operate, and seemed the most willing to offer creative solutions that could accomplish those goals without directly increasing the Commonwealth's share of those premiums, because as I mentioned, it's a legislative mandate. And they also offered some further enhancements to our claim processing and beneficiary designation procedures. This will result in a reduced administrative burden on our staff. Next slide, please. Because both life and long-term disability are what's known as age-banded products, meaning that as you get older, they get more expensive. Trying to provide a comparison chart of what the actual rates would be was not practical. So we tried to offer a couple of examples here. One is an active employee, age 38, and we wanted to show, based on a representative election of her life and LTD participation, what her premium differences would be under the new MetLife rates compared to what she would currently be paying. And then we did the same thing for a representative retiree. As you can see, the differences are not tremendous, but they are reductions, particularly on the basic life and the LTD. LTD, once again, just a quick reminder, is only available to employees who are actively working. Next slide, please. Before we move on and put things to a vote, are there any questions? It looks like Bobby has one.
Yes, Cameron, I was just curious, what is the waiting period with MetLife LTD?
90 days is the current.
Oh, it's not, so it's the same. It's the
Yes.
same. Okay. And do you anticipate actually fewer people sort of taking LTD because of the new PFML?
I would doubt that it would have much impact because the PFML is really intended as a common replacement in Massachusetts for short-term disability. Because there is a maximum of 20 weeks of benefit for your own disability, there would be overlap between when the LTD benefit period could begin and PFML. But if you remain disabled and medically unable to work beyond that 20-week period, PFML will no longer be of assistance to you, but LTD is essentially an uncapped benefit until you reach retirement age.
Okay. All right. Thank you.
Good question, Bobby. Do I have any other questions or comments or discussion about this procurement? Okay, so without any comments, I'd like to say that I appreciate MetLife being so focused on the needs of the GIC. That's always good to see. And so I'll entertain a motion to approve MetLife as the successor bidder for life, AD&D, and long-term disability. And if we can't come to a successful contract, move to the next highest scoring bidder. Do I have a motion?
So moved.
Okay, I heard from Bobby, I heard from Christy, I think I heard from Tim.
Second.
So,
Yeah.
so I will ask our general counsel to do a roll call. So for me, Andrew, I approve.
Commissioner Kaplan,
Aye.
Commissioner Roeder,
Aye.
Commissioner Butler,
Aye.
Commissioner Shabbat.
Aye. Sorry.
Commissioner Chapdelaine,
Aye.
Commissioner Choate,
Aye.
Commissioner Clenard,
Aye.
Commissioner Davis,
Aye.
Commissioner Drake, Commissioner Drake, you're on mute.
I think you might need to move on or come back to it.
Yeah, I'm going to move on. Commissioner Edmonds,
Aye.
Commissioner Gentile,
Aye.
Commissioner Murphy Rodriguez,
Aye.
Commissioner Sinenko,
Aye.
and Commissioner Timothy Sullivan.
Aye.
Is Commissioner Drake? I know you're off mute. I couldn't hear you.
Aye.
Thank you. It's unanimous. The vote passes unanimously.
Yeah, thank you. Thank you, Andrew. Thank you, commissioners, and thanks to the staff for working so hard on this. So I know we're bumping up against time. I think we may want to have one more agenda item. We might go a little bit over, but I know that it's always a popular discussion on out-of-pocket costs for our members. So how does that sound to everyone? Can we go till about 11:15 for the commissioners? Okay. I'll pass it.
I'm
over
fine
to
with that, Valerie.
Yeah.
Okay.
All right, let's push push out Jim Russ discussion if you have any questions about benefits and how we're doing on our budget. Can reach out directly to Jim. Otherwise, at this point, let's do out-of-pocket spending discussion. Margaret, I'll turn it over to you, and then we'll adjourn. Thank you.
Thank you, and good morning, everyone. I'm Margaret Anschutz. I'm our Healthcare Analytics Manager, and I'm presenting the FY20 out-of-pocket spending report for you. Before I move into the slides, I want to walk through the outline really quickly. The first part is just some definitional level setting. The second part, we're going to do a high-level look at spending across our membership. Then we'll move into those who are kind of the extreme high out-of-pocket spend. So a section on those who are over 5,000 out-of-pocket and those who are over 10,000 out-of-pocket. And then we'll move into a deeper dive into behavioral health as well as pharmacy. Okay, next slide, please. All right, this may look familiar. And again, these are definitional, and I'm not going to go into everything in consideration of our time, but I do want to level set in terms of what is included in out-of-pocket costs. So when we talk about out-of-pocket costs, we're talking about deductibles, co-pays, insurance, anything that you pay at the point of service. I want to underscore that there is a cap on out-of-pocket costs in network. For individual plans, that's $5K. For family plans, that's $10K. And the important thing to remember here is that this is a cap on in-network expenses. So there may be spending that, or there for sure is spending in an individual plan that exceeds the $5,000 cap, and that is 99% of the time because someone has gone out of network for a service and that cap is not applying. Same thing with a family plan, that cap is $10K. That's a lot of money to be spending on healthcare out of pocket. We have those protections because it is a lot of money, but then they only apply to in-network spending. So I just want to underscore that at the top because that's going to come up later in the report, and it's important to understand that. Okay, next slide, please. All right, again, this was presented last year, again, more level setting, what contributes to out-of-pocket spending and general healthcare spending. We've got general medical inflation, so healthcare gets more expensive every year. We currently have co-pays, which really shields our members very well from that medical inflation at the point of service. Claims volatility too. We're going to see in this report that, the good news is that the out-of-pocket spending is down on average across our membership. However, that's driven largely due to COVID factors and decreased utilization, as well as the waived co-pays that were put in place in the last quarter of FY20. So this is to say claims volatility is important because the more you go to see the doctor, the more chance you have at hitting, the more you're going to spend on your healthcare with those out-of-pocket point of service out-of-pocket expenses. And then, of course, plan design has an impact on your out-of-pocket, but that hasn't changed much in the last few years. So let's move on to the next slide. All right, broadly speaking, this is a good news slide. So what we're seeing now is that in FY20, household out-of-pocket on average, so this doesn't apply to everyone, but it's not 11, well, let me start over. Out-of-pocket costs are down on average 11%. So that's not that everyone across the population spent 11% less, but on average, it's down 11% from FY19. There's not a lot of mystery as to why this is. We protected our membership with, again, waiving co-pays, and then there was considerable drop in utilization in the last quarter of FY20 due to the pandemic. But the good news is we by protecting our members, we dropped from 1268 average household out of pocket to 1131. Next slide, please. So this is looking at the total out-of-pocket spending in millions across the population. We're about, in FY20, we're about down to where we were in FY17. Again, this is due to deferred care and the waiving of copays. Whereas the out-of-pocket spend is down about 11%. The GIC spending is down 1.8%. So you can see that the GIC picking up the copays and combined with the deferred care, still there was a reduction in spending, but not to the same extent that there was for our members. And again, I think this is appropriate. This is GIC protecting membership from high out-of-pockets, especially during the crisis of the pandemic that we've seen in the last fiscal year and continuing into this one. All right, next slide, please. This slide is a distribution. So whereas before I was talking about averages, now I'm talking about medians. So I'm talking about our household spending across the population still. And in FY19, half of the houses, the median out-of-pocket spending was $913. Again, the 90th percent, 2725, and the 95th, 3502. This is really a baseline slide to show you where we were last year. And we could go to the next slide. FY20. This shows the dramatic decrease in the median and the 90th and 95th percentile. Again, good news, our members were protected. All right, let's move to the next slide, slide 39, please. So we've looked across the GIC at spending and what's going on with our membership. It's helpful to have context as to what's going on out in the market as well, and where our coverage stacks up against a national database. In this case, the slide came from our partners at Willis Towers Watson, and it shows you where our plans fall with respect to kind of their overall database. What I'm particularly interested in here is looking at overall database. You see in the green, that's the member out-of-pocket costs at 14% of the total healthcare costs. Compare that to ours at 7%. Again, we're doing a good job of protecting our members from the out-of-pocket. In overall database, there are variations in actuarial value and design across industries. So another benchmark comparator that is useful in this analysis is looking at kind of the public sector, and that's the second column there. And again, we are below the government public sector benchmark of out-of-pockets of 10%, with ours again coming in at 7%. I also want to flag for you, you may see that our costs with the GIC in the third column, they are higher than both the database and public sector. And healthcare in Massachusetts is really expensive, and we know that, but I want to offer that context for you as to why, what percentage-wise we're looking good, but on absolute numbers, which is what's actually coming out of our members' pockets, you see those numbers are higher. Again, that is a function of the market that we're in Massachusetts specifically. Okay, next slide, please. All right. And here's where I think this report becomes especially meaningful. As Anna Sinico, Commissioner Sinico was saying, the importance of insurance is really shielding members against high expenses. And when we're talking about $5,000 out of pocket, that's a lot of money for anyone. So we're starting to drill into those kind of extreme high out of pocket costs. And I want to remind you, as what I said at the top of this presentation, we have caps on out-of-pocket spending. Again, $5,000 for individual plans, $10,000 for the family plans, but those caps apply to in-network spending. So if you're wondering, gosh, we have these caps, how are we over the caps? We're going to see in the data coming up, it's largely due to out-of-network spending. Okay, let's move to the next slide, please. Okay, this is the distribution that we saw in FY19. Sorry, that should read FY20. I'm sorry, that's my my mistake. This is FY20 data. And as a comparison to FY19, I can tell you that we had almost 3,200 members in the last fiscal year who were between 5,000 and 10,000 out of pocket. In FY20, we're at about 2,100 households. And that's a lot of households. And I think those households definitely feel this cost. But for context across the membership, that's just under 1% of the membership. So as a whole, we're doing really well. But I think, you know, every person who that hits, it hits hard and it merits a drill down into that data. Let's go to the next
thanks,
slide.
Margaret. Christy, do you have a question?
I do, Valerie, thank you. I was just curious, do these people, like, is there a reach out? Do these people know that they're going out of network? I mean, do you have any sense of, is this being done intentionally or is this being done accidentally?
Good question, and I'll elaborate a little bit further later on, but at a high level, the answer is it depends. I can tell you that a major driver, as we see on this slide, 44% of the households that were over 5,000, 44% of them, it was due to pharmacy spend, and ESI does send two letters to the members if they are going kind of off the benefit plan, you know, off retail services, off our benefit design, to say, hey, you know, the reason why you're paying this extra amount is because, and it lists why and how to remedy the situation. On the medical side, our carriers reach out to our members with high spending. That's more as a function of chronic care management and the health management that that our carriers fulfill as part of their roles working with us. So yes, there is outreach. I can't tell you on a case-by-case basis specifically, but for sure on the pharmacy side there is, yes. Okay, so here we are with characteristics of these high expenditure, out-of-pocket expense families. Not surprisingly, large family size was a driver of high out-of-pocket costs. You know, the more people who were seeking healthcare in a plan, or the more out-of-pocket spending there's going to be. So what we saw in FY20 is that the average family size the average family size of a household was 3.1, which is compared to 1.95 of our full membership. So again, as you would expect, more people seeking care within a household is going to, you know, you're going to get up to your deductible faster. As I mentioned, 44, okay, so as I mentioned, ESI reaches out to their pharmacy, people who are exceeding, but I pulled the wrong number, and I'll get into the EIC or the pharmacy numbers later, but the 44% here in front of us is the number of households from FY19 that were also FY20 in the FY20 high out-of-pocket utilizers. So that was about a third of FY19's above 5,000 have returned into that group in FY20. Again, I think it's important to put some total healthcare spending context around the out-of-pocket report for this group that we're discussing now, the over 5,000. On average, the GIC's contribution was 117,000. Again, to Commissioner Sinaiko's point, this is an example of, you know, health insurance protecting members from these really high medical costs. although, you know, still at 5,000, that's definitely felt by our members as well. 600 of these members had total costs over 100,000, and 185 had costs over 250,000 that was carried by the GIC. All right, next slide, please. This slide, again, on the 5K plus population is a look at the diagnoses of our members who were over 5,000, and also the proportion of care that was in network in the blue, and the proportion of care that was out of network in the red. What's most striking to me in this case is the high proportion of out-of-network spend in the alcohol drug diagnosis. We saw that last year as well. And I think the commission at this point is very familiar with the fact that demand outstrips the availability of high quality in-network treatment options for a substance use disorder. And that is a policy area that is of great importance to the Commonwealth, great importance to us and our carriers, and we're watching that closely. I can tell you that this alcohol drug spending decreased relative to last year. I'm not sure that that's a good thing. Anytime mental health spending and utilization goes down, or behavioral health more generally, I'm concerned that people aren't getting the care that they need. Also, in the time of COVID, I think there could have been reluctance to seek care. And I think that a lot of these treatment facilities were also having their own problems or own challenges keeping the facilities free of COVID. So I think that's why we see some of that. Let's move on to slide 44, please. So whereas the last slide was diagnosis of members, this is the services our members were seeking. I want to flag on this slide specifically, we, again, as you would expect, we saw a decrease in the amount of spending over the fiscal year. You see over on the right side of the slide that, that pharmacy is a huge expense. Having said that, it was still down $1 million over last year. Primary care spending was down $1.5 million, and inpatient hospital was down $1 million. But particularly of note, you know, inpatient hospital is a very expensive category to be in, and I find that roughly 50-50 break in network and out of network inpatient hospital concerning, to say the least. That means that a lot of people are going out of network, and that is a big bill to foot out of network. All right, that'll sum up the 5K population. If there are no questions on the high out-of-pocket households over 5,000, I'll move to the high out-of-pocket households over 10,000.
Yeah, and I see Bobby has her hand up. I wonder if we can take questions at the end, or Bobby, do you feel like your question would be better served at this point?
Well, I don't really know, but I would like to speak now. I might have a different question with the 10,000, but I'm very curious, Margaret, about first of all, whether the pharmacy, the ESI outreach has produced any positive results, like have people changed or gone to their doctors, because frequently the physicians do not want to change the medication, even though ESI may recommend an alternate medication. So I'm very curious what those results, if any, are. Regarding I'm curious about first of all, the inpatient, if that is more, if that's COVID related, that people have gone out of network for, if it's COVID related this particular year, or is that a trend that we are seeing? And I'm assuming that may be linked to the number of people who are in limited networks, who select that plan, and therefore everything is out of network. And should people, be informed about that? Because I know in speaking to members, a lot of them are surprised they have a limited network plan, but they can't go to Mass General, right? So I'm very curious about that. And should that be something that we address, in the future?
These are both good questions. So as far as ESI's outreach, I want to first clarify most of the high out-of-pocket spending that was related to pharmacy. It tracks back to maintenance medication that you pay a higher copay if you go pick it up in person versus having it mailed to you. But I think your point about whether the ESI outreach is effective, I think that that's still a good point, and I will follow up with ESI to find out if
Margaret,
yes.
it's Denise. I'm sorry to interrupt. I just wanted to say the other really important point to understand about the quote unquote out of pocket spend on prescription drugs is that ESI is telling us that they think many of these people are not responding to the multiple outreach efforts that ESI makes, is because either they have manufacturer coupons or they are covered by TRICARE as military veterans. And we have no way of tracking that. So we are not certain that the quote unquote out of pocket here is actually being spent by these individuals.
So that's a really important point, and that's essentially, there's some coordination of benefits going on here where we would not be informed. Again, as Denise said, that if and I saw in the data I got back from ESI that a number of our high pharmacy out-of-pocket spend members also picked up their medications at say the VA, where we would believe that they had the rest of the out-of-pocket covered. So it's an issue. It's an instance where claims data doesn't match up 100% to our members' experience, so that's an important caveat with the pharmacy spend. As far as the inpatient spending goes, I'm looking at last year's report, and the proportion of out-of-network spend was not as high as it is this year. I don't have this disaggregated, meaning I can't tell you what exactly those that spending was related to. If it was COVID, it could also be related to, I would guess, substance use disorder treatments, inpatient stays, and we see a lot of that's out of network. So that would be the first place I would look. But I will follow up on that once we have our new database up and running. I can give you a breakdown. I'd be happy to. Okay, I know we're crunched for time, so I want to keep going. Let's move to the next slide.
I think what we should probably do is try to get through this next section, and I think we're just gonna have to leave the behavioral health and prescription drug drill downs for a future discussion. That would be my suggestion.
Okay. All right, so the 10K population, let's go ahead and go to the next slide. Okay, so the 10K population is where we really saw with ESI the maintenance medication being picked up instead of being received through the mail, that parameter of the plan being broken by members, as well as copay assistance from the VA or whatever mechanism our members received copay assistance. you know, as I mentioned, the plans do outreach to these members to engage them in care management plans. Of all of the members that were eligible for care management, only one engaged in FY20. And really what we saw that, as Bobby guessed, that the highest medical out-of-pocket costs were driven primarily by out-of-plan facilities for people who were enrolled in a narrow network. Having said that, we still had a decrease over the last year in the number of people who were spending out of pocket more than 10, or not people, subscribers, families, or individuals who were spending over $10,000. Last year, we saw, I believe it was 92 households over 10,000, and this year we were at 79. And let's move to the next slide. These are the diagnoses, and for the members over 10,000. What I really want to point out to you here is how much more the red pops, and that would be expected. Again, the red being the out-of-network spending, and what we see in the main difference between the diagnostic category breakdown in the 5K plus versus the 10K plus is we see a lot more red on this graph. Again, I would expect that because out-of-network costs are high. And if you're covering that, the people with the highest out-of-pocket spend, it makes sense that they would have a lot of out-of-network spend driving that. So again, we see here the over 10,000, we've got alcohol, drug treatment as predominantly out-of-network. Again, that is something that we're looking at as one of our priorities, behavioral health access. We also saw that that mental health jumped up over last year. That's also not surprising as people seek care during the pandemic. All right, let's move to the next slide, please. And these, again, are the services that our members are seeking. And we see inpatient hospital, again, very high out-of-network proportionally. And again, I would speculate that would be related to substance use disorder treatment. Although, Bobby, I'll do a follow-up report on the high out-of-network spending and what's really driving that. And I'll do some drill downs there. So we'll stop there and take some questions, and then I guess follow up at the next meeting. Is that the plan on a deeper dive into behavioral health and pharmacy?
Yeah, I think it's important to at least take a whack at trying to fit some of this in. I appreciate the patience of some commissioners here. I think part of the reason for us trying to kind of get through this is that it fits with our prior discussion about plan design, potential plan design changes. We can have a better sense of the wisdom of that strategy by understanding what the out-of-pocket burden is on the part of our members. So we wanted to have that here so that we could, so that we don't lose track of that in the other discussion. So I know we are pretty much now at time. I defer to my chair as to whether we take a question or two here. We are happy. There's a lot of information here and several slides that we just did not get to, including one on kind of our race and ethnicity data, emerging plan, which we want to continue to engage the commission on, but we can also pick up those at the next meeting and are happy to talk with anybody offline about those as well.
Yeah, no, I think in the interest of time, maybe we can take one or two questions and then for the next meeting, potentially spend some time reviewing, the key learnings for the 5,000 and 10,000 out-of-pocket households, and then move on to behavioral health and other topics for out-of-pocket costs. But I do think this was important to tee up the conversation about potential benefit designs, which we did discuss. I think that will inform our thinking for the next meeting. How's that sound to my commissioners? Bobby, go ahead. Bobby, did you have a question, or is that a hand raise?
She's on mute.
Bobby, you have to take yourself off
Sorry,
mute.
yeah. So first of all, I thought we had the meeting was extended till 11, and I'm very interested in the race and diversity, which I would like to see. I mean, I know we have a few minutes, because otherwise, what's the reason for the extension? You know, I sort of feel rushed, like we can't ask any questions, and I apologize. Sometimes my questions are pretty long, but I think it's important for us to ask those questions and to get answers before we make decisions. And so I would like to at least know about that.
So Bobby, thank you for bringing that up. I have a very, very hard stop at 11. And so, you know, it's important that we maintain our time. And I feel like in the 13 minutes to go over both the data and to have enough of a robust conversation, it's not fair to that topic. So I'm trying to manage the agenda so that we absolutely end at 11 o'clock. And I don't feel, based on our past experiences, that it's enough time to go into this in the attention it deserves. So I'm suggesting that we move it to the next meeting so it can get the time and attention it deserves. And I'm seeing a thumbs up from Jane. So nice job, Jane, thank you. So, you know, feel free to ask a question or two about the 5 and the 10,000 out of pocket, Bobby, and then we'll pick it up at the next meeting. I certainly don't want you to feel rushed in any way.
Yeah, that's I just wanted to say, you know, so if we're pushing it to the next meeting and we're going to have a discussion leading to a vote, you know, like, are we going to push everything forward? In other words, for like, if we don't finish, like, how do we know the same thing won't occur next meeting? I guess it's
it's an excellent question. I do think that I will work more closely with the staff of the GIC to make sure we stay within our time limit. And you know, we need to have tight agenda management. We've historically had multiple meetings during, you know, rate setting and plan design sessions. I think the staff is trying to manage to that so that they don't incur additional meetings for us. So I do appreciate that. I don't think there's a vote on out-of-pocket costs that is required. So, you know, there's no urgency to cover this today. So we've done our vote, which is great. And, you know, the staff has their marching orders. So, you know, this is good information on the $5,000 and $10,000 out-of-pocket costs that will help us at the 4 public meetings that we have coming up. And you have all the data, and it's also posted. So the behavioral health and the race and ethnicity data is available for review. And it does sound like the staff are happy to take your questions and comments in between this meeting and our February 4th meeting.
May I just add one comment? I completely understand the time constraints, and that's why I want to support what you're suggesting as chair. At the same time, the urgency of of a discussion around that subject matter. I am grateful to Commissioner Kaplan for continuing to raise it, and not, frankly, put me in the position where I feel like I'm saying the same thing over and over again. And I believe that we need to have the discussion seen as a important discussion and not one that's left to the end of an agenda and squeezed into time. the positioning of it is frankly somewhat disappointing. And so I very much would like to see us make sure that we give it the time deserved.
Yeah, no, I think that's a good comment, and I believe that my recommendation as we started this conversation was, let's bring this up as the first topic at the next meeting so that it gets the time and attention it deserves. So I'm also in support of that, Jane, and I think that we've teed up the conversation, and so I do feel like we've given Margaret probably more work to do potentially, because she has a couple more weeks to bring us data on this subset and discussion part of the out-of-pocket costs.
I do want to manage expectations just a bit in that we don't have a data warehouse up right now. So I pulled all of this in December before Optum went dark, and now we're building Milliman. So I can't do much of a drill down between the next meetings. But I as soon as I have my data back, I will.
Yeah, and Margaret, I would encourage you, and I'm sure you're doing this already, but to talk to the health plans and see what kind of data they might have between December and February, and encourage them, because I feel like we have a good clout here in Massachusetts. And so, we have a responsibility to push them to be more innovative, and they have access to significant data. And while it might not be specific to our members, it could inform our thinking, because our membership is such a big part of Massachusetts. So what do they have, and what are they doing, and can they augment it? And what can you share with us about what they're doing, because we're such a big part of what they do.
Yep,
and I'm sure you're doing that already, so I'm just encouraging you to keep doing more of what you're doing. So Bobby, I want to make sure that if you have questions on the slides that Margaret just presented, we still have 7 minutes before we have to adjourn.
No, I don't. I don't have any questions.
Okay. All right. Well, I'm somewhat pleased to see that out-of-pocket costs went down year over year, but I know it's the extraordinary nature of the year. So I'm not sure if that's good news for our constituents. But I do appreciate the data, and I'm looking forward to picking this conversation up at the next meeting. So I know, Jim, you were going to present on where we were on budget. Do you want to spend a minute or two? Not that your section is any less important, but I know we're right at our allotted budget by the administration. Anything to add? Anything you'd like to have us discuss or no?
I think we're in the same basic position we were at mid-year as we were last month. So we're favorable to budget by a fair amount. A lot of volatility due to COVID claims. We're seeing an increase in COVID claims, and that's about the picture. I have the standard slides. If anyone has any questions on them, feel free to reach out anytime, and I'm happy to answer them.
Yeah, no, thank you for keeping us on budget and giving us that update. Appreciate that. All right, Matt, anything final to add to the discussion here today? I think you've heard loud and clear from commissioners that we want to make sure we position this out-of-pocket cost report, as well as the diversity and inclusion data, so that we can be leaders in this area in healthcare in the upcoming year. So let's make sure that gets front and center attention. And we've talked about the benefit design and the public meetings, and making sure that we have access for constituents to weigh in. So I think those were the takeaways from the commissioners today.
Thank you, Madam Chair. And we do hear that loud and clear. Certainly appreciate all of the feedback and guidance from commissioners. One of the things that I always want to provide for you is an opportunity for us to have non-rushed discussions on priority matters. So we will endeavor to up our game and meet that goal as we, manage all of the key decisions that we actually have to make at each of our meetings. But we will endeavor to do better there. So thank you for your guidance and feedback and patience with us as we make improvements in that regard. So thank you all.
All right. So without any further comments or questions, I don't see any other hands raised. I will call this meeting adjourned as per guidelines for virtual meetings. So thanks, everybody. We'll see you in just a couple of weeks at our February meeting.
Thanks so much.